Hello guys, good evening everyone. So are we ready to join the Fundus Walk session? So evening 5 on Sundays we have our Fundus Walk, and today can anyone guess what is going to be the fundus that we are going to discuss today? Okay, so I will probably give you a clinical scenario, and without the fundus you should be able to tell me a differential, and then probably from there you should be able to tell me what is the fundus that we are probably going to discuss today. So there is this 55 or 50-ish odd old gentleman who has history of hypertension, uncontrolled hypertension, on medication but still uncontrolled. Now he complains of a sudden painless decrease in vision, which he particularly says he can't see the lower half of his field on his left eye. Okay, on his left eye, through his left eye he can't see the lower part of his field. Yeah, so that is the presentation. So what do you think would run in your mind, and what is the fundus do you think, the condition that you think we're going to discuss today? I'm not giving you options, it's just a random differential diagnosis that you can tell me. So we have a 50-ish odd year gentleman, hypertensive, on medication but uncontrolled, typical, no, uncontrolled, and he wakes up to a sudden decrease in vision, which he characteristically describes as the lower half of his vision. He can't see lower half of his visual field. He can't see on the left side, on his left side, only on through his left eye. What do you think is the fundus we're going to discuss? What is the differential diagnosis that is running on your mind? Any idea? All right, so let's take a look. So are you ready for the fundus? So we peep into the fundus and this is what we get to see. Yeah, so we see his left fundus. Now I know this is left fundus because my optic disc is nasal, so that means this is the nose. Now here I can characteristically see, now as I keep telling you, taking you through the walk, you tell me as you can appreciate it. Are you able to see the normal color of the fundus here? Yes, the lower part. Can you see the normal color of the fundus here? Are you able to see the normal color of the fundus here? This portion? All these areas, are you able to see the normal color of the fundus? Yes, because the retina is transparent, so you're able to see the orangish red color of the fundus. Yes, are you able to see that? Yes, are you able to see that, guys? Yes, good, Shweta. Good, you've been answering, Shweta, very good. Participate in all the Let's Do Opthal MCQ series. So you can see wherever I mark the tick, you can see the normal color. But in this area, do you see the opaque retina? The retina here in this quadrant is opaque. Very good, Shweta. Yes. So it is opaque. So you get a milky white, although I know that's a bit of an exaggeration. Milky white. So this quadrant, yes, it's a milky white retinal edema. So this is a superotemporal branch retinal artery occlusion. Okay. Now, let's go on to see what I can see here marked on the arrow mark. If you can see the contrast, see it. See, first of all, this is the vein. The darker thing is the vein. You can hardly see the artery here. The artery is so attenuated. It's so thinned out. Are you all able to appreciate? Give me a thumbs up if you're able to appreciate the thinned out arterioles. Only in this quadrant. See, in the other quadrants, they are normal. The other quadrant, look, in the lower quadrant, the arteriole size is normal, kind of normal, not that bad as in this quadrant. Yes, are you able to appreciate it? Give me a thumbs up if you're able to appreciate this. Okay, now what is this arrow pointing to? So it is pointing to Hollenhorst plaque, which is stuck at an AV junction, one of the branchings, or here it is not AV junction, it is a arteriovenous, I'm sorry, it's a artery branching. Okay, so at that area it is lodged there. So that is a Hollenhorst plaque. Can you see that refractile body there? Can you all see that? Give me a thumbs up if you are able to see this. Are you able to appreciate it? So this is occluding one retinal arteriole, a branch. So this is a BRAO, okay, branch retinal arterial occlusion. Yes, clear everyone? Yes, so this is a branch retinal arterial occlusion. So this one is typically a superotemporal quadrant. Yes, which is affected. Which part of the retina is affected? The superotemporal quadrant. So what is the typical field defect that this patient will have? See, when it is supero, so this is the superotemporal quadrant. Okay, so that means meow. All right, hi, who is this? Meow. All right, so that is we have a cat here. All right, so when you have a superotemporal quadrant affected, guys, please remember your retina, you all must have learnt in physiology, and I have taught you in neuro-ophthalm, that your superior retina serves the inferior field. Yes, similarly, inferior retina serves the superior field. Whatever is located in the superior part is served by my inferior retina. Similarly, my nasal retina looks at temporal field or serves a temporal field, and my temporal retina serves a nasal field. So in this case, if my superotemporal quadrant is affected, yes, where will be my visual field defect in this case? The patient will not be able to see the superior means inferior, temporal retina means nasal. So the inferonasal quadrant, he will have a visual field defect. Yes, very good, Vinod. Yes, perfect. Understood. Now, will he actually have a decreased vision as such? See, that is why I gave a clinical scenario here where this patient is having only a visual field defect because his macula is not really involved in this. See, macula is a little here, okay, a little inferior to the horizontal midline. I mean, it's a little here, but yeah, kind of. The foveola is kind of spared here. So his visual acuity itself may be normal in this patient. Okay, the visual acuity itself may be normal, and RAPD may not be present. See, RAPD will be present only when you have extensive retinal lesions. Do you understand? See, the macula is, I'm sorry, not macula is the entire area. What I meant to say is the fovea and the foveola. So foveola is just here. See, the foveola is spared in, oh God, sorry guys. So the foveola, where what I marked in, what is happening? The foveola that I marked here in a small circle. Where did that circle go? It's like magic. I'm showing magic here. All right. Okay. So that is the, sorry, with this color, I'm finding it difficult. All right. So guys, do you see that? So the area where I marked that little circle, that is your exact foveolar location. Foveola is not involved in that frosted appearance, in that white opacity, okay, the opaque retina. So probably this patient, the visual acuity itself will be normal, yes, but he will complain of a visual field defect, which would be inferonasally only on the left eye. Okay, right eye will be completely normal. And RAPD, please understand, pupillary light reflex would be normal unless there is an optic nerve problem or an extensive retinal problem like a CRAO, which is massive. Okay, central retinal artery occlusion is massive occlusion, so there we can have RAPD. BRAO, branch retinal artery occlusion, like this one, slightly lesser chances. And again, most common cause of BRAO, same thing like CRAO. Okay, it is hypertension. And in Younger individuals always try to rule out giant cell arteritis as well. Yeah, giant cell arteritis also can be a cause of arterial occlusions, both central retinal artery occlusion and branch retinal artery occlusion. So this small thing that what happened? So you can also see the Hollenhorst plaque. Yeah, okay, I'm just marking that for you. So that small refractile body is a Hollenhorst plaque. All right. So Hollenhorst plaque is not necessarily only in central retinal artery occlusion. You can see it even in branch retinal artery occlusion. And what is a Hollenhorst plaque made up of? Yes, that small refractile body. Can you see? All right. Now, I just want you to have an open mind and look at this image. Yes. So again, do you think it is an arterial occlusion? Yes, Vinod, very good. Hollenhorst plaque is made up of cholesterol. It is a cholesterol plaque. Now, look at this image. So, can you see a clear difference in the color between the fundus below and above? This one, arey yaar, what is this? Okay, so can you see the difference in the color between, guys, what I'm trying to show you? Yes, so again left fundus, because my optic disc is here, it's nasal. Yes, and can you see the difference? The normal color below and almost it's the entire upper half, there is this occlusion and therefore there is a retinal edema. Yes, can you see that? And can you see all these arterioles? All these arterioles are attenuated, whereas below you can see the arteriole kind of, yeah, it is little bit attenuated but not entirely collapsed like these. These are like, there's just streaks there, completely collapsed. So what do you think this is? So this is a hemiretinal artery occlusion, half. Yes, that was branch. So this is the superior half. So this patient will have the entire inferior half visual field defect, and probably even the fovea is involved here. Yes, correct. Although we don't write anywhere as HRAO, but yes. So do you understand? So you can get a visual field defect. All right. So I will also show you the previous Sunday's discussion which we had, which was central retinal artery occlusion, which involved the entire macula. Yes, can you see the entire macula involved? And you got that beautiful cherry red spot. See, as long as the macula is not involved, you will not have the cherry red spot, or as long as the foveola is not involved. See, only when that area is involved, you will have foveolar sparing and therefore cherry red spot. So, do you see that? Very good. See here, the foveola itself is not involved. So, that is why it's neither involved nor spared. So, no cherry red spot. If it is involved, then maybe you'll get cherry red spot. Okay, so here again, see, the foveola is not involved, so we don't have a cherry red spot. Understood? Clear? If that opacity would have extended to involve the foveola, then probably we would have had, where I marked that black circle, probably we would have had a cherry red spot. Is that clear? So management is essentially the same, just like how we discussed in central retinal artery occlusion. Okay, so Pakka, clear, so far we've discussed in this series that we've started, we've discussed central retinal vein occlusion, branch retinal vein occlusion, central retinal artery occlusion, branch retinal artery occlusion, and kind of even hemiretinal occlusion, artery occlusion. So perfect, imprinted in your brain. Yes, those are the other causes of cherry red spot. All right. Okay. So guys, I will see you at 6 p.m. with our images that are waiting to be decoded. Yes. And again, guys, you are asking me how to join the test and discussion. Test and discussion, I've given the link. Okay. I've given the link in the description, I think. So just click on that. You'll get the details and you can join us. All right, and I will see you at 6. And tomorrow we have a quiz. Today we don't have a quiz. So tomorrow 6 p.m. quiz on the Telegram group, which is Neuro Ophthalm quiz. Okay, and Pongal is coming, Makar Shankranti is coming. So we've put up because Pongal is a big festival for us, for Tamilians. It's a big festival. So of course, how can we leave out giving you good offers for Pongal? So Pongal offer is there on EyeMentor app on all the courses and all the books. And those of you going for exams, final year exams, you want to have a hard copy of the book for just 1 month, ping me. Okay, you can WhatsApp me. 1 month course with the books, just WhatsApp me 9363435748. All right, so I will let you know how to get access to the course. All right, guys, so see you at 6. I hope these Fundus sessions are useful for all of you. Bye bye.